Oh, okay. Okay. So let me pull up, actually, let me pull up the questions first, too. Okay. Hi, it's Amanda here with COVID-19 Long Haulers Discussion Group. Taylor is probably still a little numbed up from the dentist, and that's okay. We have Dr. Natalia here. Hi, Dr. Natalia. How are you?
Hi, Amanda. Thank you for having me.
Well, thank you so much for agreeing to do this with us. We really appreciate it. Tell us a little bit about you, and then we'll dive into these questions. You don't have to like give us your address or anything.
Well, I am a critical care physician. I work in the ICU and I deal with all kinds of patients. And of course, I deal with long COVID patients who end up in ICU.
Great. Thank you so much for your work and also for everything you do online for the online community as well. I really thankful for it. So we'll just dive right in. What are the symptoms of a heart attack? What should we be looking for?
Well, heart attack unrelated to COVID or related to COVID will have the same symptoms, right? So, heart attack usually is very severe. Classically, let's put it this way. Classically, it's very severe chest pain. It can be retrosternal, so where your chest bone, behind the chest bone, you can have very severe pain. And classically, patients described it as elephant sitting on the chest, or there is some kind of pressure, or there is a squeezing pain. The pain can radiate to the jaw on the left side, it can radiate to the back, or it can radiate to the left arm. So those symptoms are classic symptoms. However, heart attack doesn't always present with that much of a chest pain, and in some situations, it may not have chest pain at all, which makes it a lot more confusing. And particularly in women or elderly people, heart attack can present with nausea, can present with lightheadedness and dizziness. It can present with severe fatigue, which again, in the setting of long COVID, when you already have fatigue, it may make it difficult to recognize. And it may, as I've said, it may come with nausea. And again, with long COVID, some people have nausea, right? So um, it can come with shortness of breath, which again, in a setting of long COVID may be hard to recognize. However, I would say in a long COVID, when you have a baseline feeling bad and suddenly you start having discomfort, it may be something that is feeling like a GERD, right? So it's still like a reflux, like an indigestion. It's sudden, it's new, and it's sudden, and it doesn't go away, or it's nausea and it doesn't go away, and it just stays and it's bothersome, it's debilitating, or it's fatigue that you suddenly cannot get up from bed, and it's new. It's worsening of the one that you have now baseline. I would say then start looking for care, start seeking care at that point.
Yeah, I think that's really the key is it new? Is it sudden? Is it yeah, you're right. A lot of these things can be confusing. And as you're listing symptoms, I'm like, oh, that's me. Oh, that's me. That's me too.
Well, yeah, that's the
Yeah.
thing. And this is the thing, especially in females, very often it doesn't come with that as classically described elephant on the chest pain, right? So it comes usually with, especially elderly woman comes in complaining, not feeling well, and usually women start thinking, I have an indigestion, or I didn't sleep well, I am dizzy, I tried to get up and I'm dizzy, but probably, and usually women start thinking of, oh, I didn't take my medication, or maybe I took my medication, or I was too tired, I didn't sleep well, or I'm having my GERD and my nausea together. And they present late because there is no awareness that those can be symptoms of heart attack.
Yeah, that answers our second question about the differences between men and women. Are there? It sounds like, yeah. Another person asks, do new onset cholesterol level changes or increases put someone at more risk?
Well, of course, cholesterol has been a known factor of atherosclerosis and known factor of diseases connected to atherosclerosis. So we keep coming with different data. Bad cholesterol, good cholesterol, how much, how should we lower bad cholesterol, how should we increase good cholesterol. But once somebody starts having changes in their lipid profile, we call it lipid profile or lipid panel, right? So if you go to a doctor, the doctor orders a lipid panel. And once you start having this balance between good cholesterol and bad cholesterol, we know it's a risk factor for having atherosclerosis. So those fat plaques, cholesterol plaques inside the vessels, and they can cause heart attack. They can cause other conditions such as strokes as well, with narrowing flow in the brain. Therefore, that needs to be addressed with the physician who treats you. And I think there are different ways. Some may choose to try diet. As we always say, the first step could be diet. However, depending on the level of a bad cholesterol, it may need to be medications right away. So depending on how high the level is and how determined person is to do diet, because diet sometimes is, I mean, diet generally is hard. It takes a lot of discipline than taking a pill. So diet, but with, I would say, maybe when there is a not very high levels, and I'm not going to go over levels, but it's because, as we have discussed, it's not medical advice for any particular person. Like, you need to discuss this with your doctor. Depends on all the other risk factors, depends on all the other conditions that person may have, such as diabetes, increased weight, or hypertension, or kidney disease. There will be a choice of what a physician would advise a patient to do, but definitely a cholesterol needs to be addressed one way or the other.
Sure, we've got Taylor coming in now. Give him a second here. Yeah, and that's something we've really tried to stress in the group, is that none of this is medical advice. Please do not give medical advice in this group, because unless you are a physician actually treating this person, you know this person, you know their history, even then you should still not be doing it online.
Well, absolutely, absolutely. And this is why I always say we never treat anybody by the photograph. We don't treat anybody just by the table. Like, sometimes people send me a table with their results or their chemistry profile. And what do? I am not your physician. I will not be able to. Hi, Taylor.
Hey. So we've just gone over. How are you? How's that?
I'm good. How are you?
Okay. I'm great, thank you. So we've just gone over some of the symptoms of heart attack, how it might present differently between men and women. And so why don't you, do you want to chime in with anything? Like, yeah, you've seen things, so.
Yeah. I'll start just by introducing myself. Sorry for joining late.
No, you're fine.
I was talking politics with one of our med Twitter colleagues who's running for office. I'm Taylor Nichols. I'm an emergency medicine physician in Northern California, hence my background. And yeah, we treat heart attacks and all sorts of emergency conditions in the emergency department. Heart attacks being, or I would say chest pain being, one of the leading things that brings people to the emergency department, one of the primary chief complaints that we see. And heart attacks often will present with chest pain, but that's not the only thing that they'll present with. We see them presenting with a variety of symptoms. Now, people present more commonly in different groups with different symptoms. So it's important to make sure that we don't only think of chest pain as the only possible presentation of a heart attack. But the most common in all groups is chest pain. It's often either chest pressure, can be across the whole chest, both sides, but your heart is located sort of right here on the left side of your chest. And so most often, if it's localized, it'll be on the left side. The pain can radiate. So as in you feel the pain in one place and then you feel that pain sort of spread, or you feel it go to your shoulders, your arms, your jaw, your neck are sort of the common ones. And then sometimes your back as well. And then those are sort of the common things. The alternatives that are important to check with patients about is that nausea, sweating, and then just what we call epigastric is like the upper mid abdomen. So epigastric pain, because your heart sits right on your diaphragm. It's like right on top of it. And so the diaphragm is separating all of your abdominal contents from your chest contents, right? So it's sitting essentially right up above your abdomen. And your abdomen does go up that high. Your diaphragm kind of has this elevated shape, and your heart's sitting right on top of it. And so you can have people, I've had people present with epigastric pain and nausea and vomiting and sweats. And sometimes that's just a run-of-the-mill food poisoning, and sometimes that's a heart attack, right? So it depends. More common in women to present with nausea and more subtle symptoms than in men. So it's important to be mindful of that, but I wouldn't ignore it in men either. If they're like, oh, I have epigastric pain and nausea and I'm sweaty, and then like, oh, well, you're not a woman, I'm not gonna like check for the markers of a heart attack in your blood. Like, you should check for both, but also make sure that you are sort of a little bit more attuned to that in women. Those are sort of the most common things that we see, but even things that aren't associated with pain at all. Sometimes it's just nausea. Sometimes it's, I suddenly felt this like weakness that I will say, this is just my own personal experience. I've seen that more commonly in older people, like elderly patient population. Often when you have a little bit more difficulty sort of describing symptoms or pinpointing them, they're like, I don't really know what happened. Is she was fine, and then she just kept saying she felt weak. But it like starts suddenly. It's like, that's weird. Why would like weakness start suddenly? So things like that. We check what we call a biomarker or an enzyme in the blood called a troponin. And so in patients who do present that way with any sort of variety of those symptoms, I'll send a troponin test on just to check if it could be related to a heart attack.
What we discussed also, just want to say that we have mentioned that all this non-chest pain symptoms may be confusing in a patient with long COVID, because they do have nausea and they do have some shortness of breath, and they do have some other like this epigastric pain, right? So the indigestion, and this is what it's being referred to sometimes. Oh yeah, I have my reflux, I have, you know, indigestions, right? So, and that's exactly what I've mentioned before, that the sudden onset, the worsening of your baseline symptoms, that would definitely trigger necessity to see a doctor.
I think that's very well said. And I would say any of those symptoms, even in the setting of long COVID, which can certainly help mask or contribute to that, warrants a visit to the emergency department. And I know that it's complicated because we have a very broken healthcare system. And I know that there are a lot of barriers for people to, one, accessing care, and two, desiring to access care. And I know that there are a lot of reasons that people have concerns about biases that they will face in the emergency department or just in healthcare in general. But I still think it's important to come in if there's a concern. And it's also important to say what you're concerned about, because I found that, having done this for over a decade now, I will think one thing, because you say all the sort of words that like lead me to a conclusion, and then you may be worried about something completely different. And I might be like, oh, for example, you say like, I'm having upper abdominal pain and nausea and I'm sweating, and I'm like, you might be having a heart attack. And they're like, I just need something for like my upset stomach, or like I got food poisoning, just can you prescribe me something for the nausea? And I'm like, I actually want to do something totally differently. And so if you came in and you're like, I have this and I'm worried about a heart attack, that helps me know that's something that, one, I should be paying attention to, because if that's a concern of yours, it should be a concern of mine. And two, that's something that I should test for if it's something you're concerned about. Now, if you're like, oh, I'm having like toe pain and I'm also worried I'm having a heart attack, but for no particular reason, I might like talk it through with you and try and understand why, but like, I might be able to explain like those are not related. So, but regardless, even if you were having toe pain and worried that you had a heart attack, I would want to talk to you about it. That's important for me to know. And I want you to come away from that experience having those questions answered, even if that's not the problem at the moment. If that makes sense. So if you're like, I'm having chest pain, I'm worried. I have people say this to me all the time, and it makes me really sad actually, where they have chest pain, they come in, we send often 2 troponin tests, because one test is just a snapshot in time. We want to see a trend. Sometimes we can do it with only one, depending on age and risk factors and that sort of thing. But I'll often send 2, and I'll send both, and it takes a bunch of time, right? And then they're like, oh man, I'm so sorry that I like wasted a bed for multiple hours. I'm like, literally, you came here because you were worried that you were having a heart attack, which is an emergency. And you came to the emergency department so that we could do that. The fact that you aren't having a heart attack is a good thing, and you're not wasting my time. That's literally why I have a job. And if everyone who came to the emergency department was having a heart attack, I would be incredibly concerned that we were missing a ton of people who were actually having heart attacks, right? So like our like quote unquote hit rate for heart attacks should be very low. Like 99% of the people that I send a test on for having a heart attack should not be having a heart attack, because if that many people are having a heart attack, and if that many people that are actually coming to the emergency department are actually having a heart attack, then we're missing a lot. So it's okay to come in when like you aren't truly having an emergency, and that's all right. That's literally like what we expect. That's what we want to see, because we'd rather have people not have heart attacks than have heart attacks, right?
Well, and I think another problem that we've run into, especially in the long COVID community, is the cost. And that just really, that breaks my heart. Like, you're life has no price tag. Please go in.
Right.
Oh,
So I can speak to that a little bit, and in terms of ways to be cost conscious, if that's probably the best way you could phrase it. There's no way in our current healthcare system to escape the issue of cost, right? It's the single greatest barrier to having trust in physicians, having access to care, having it's the leading cause of bankruptcy in the country. And it's really one of the biggest problems facing healthcare, in my opinion. If you have insurance, make sure that you're going to a hospital that is in your network, right? So your insurance, the first place to check is your insurance. Until it does get more complicated. So hospitals are the physical space. The physicians who work in the hospitals are not, and in most states cannot be, employees of the hospital unless it's like the VA. In which case, they're their own physician group that contracts with the hospital, and they contract separately with the insurance than the hospital does. That's where the idea of in-network costs can vary, and what's called surprise billing or balance billing is the more accurate term comes into play. And that was what the No Surprises Act was supposed to fix, to settle this idea that the patient is stuck in the middle for that. It should, and if any balance billing becomes a problem, make sure that you bring that up to the insurance company, because that shouldn't happen. Like, what's supposed to happen is that there's supposed to be a negotiation that occurs between the physician group and the insurance company, because the physician group can say, well, we're not in network, even though the hospital is in network, and this is what we're charging. So it's supposed to be a negotiation about what that bill is. The patient should not be left in the middle. And I know it sucks to have to feel like that's a risk, and then you have to be your own advocate. Although, of course, the COVID long hauler community is used to being their own advocates, right? This is just another place that may happen. But it's important to be mindful of, because if you do get stuck with a quote unquote surprise bill, that should be dealt with. There's legislation that was passed about that issue. So that's one thing in terms of being more cost conscious to make sure that you're aware of. So going to in-network hospitals, then if you happen to be treated by a non-in-network physician, that should be managed. You should not be stuck in the middle.
I would add something also, that if you don't have an insurance, it is important to know what your public hospitals are and your county hospitals. And those county hospitals will treat you and will provide you standard of care, and they will ignore the fact that you don't have insurance. So I do work in the public hospitals, so I would recommend that you know for your county where you live, where your public hospital is. And even for outpatient settings, usually public hospitals have clinics attached to them. Usually they're very busy and the wait time may be long. However, you still will get care there. And there are also community health centers. And before you start having health problems, you may want to establish care with community health clinics where you will, when you don't have insurance, you will get served. You may have to pay some price, but the price will be much lower, a very small price based on your, I think, income. And there is a paper, like a set of papers that you need to bring to those clinics. But usually clinics, even through those clinics, you can get prescription medications for a lower price or at no price, at no cost for you. You can get things, since we're talking about chest pain and a heart attack, you can get a stress test in those clinics, and you can get some additional work, like we've talked before about lipids and maybe check your thyroid and some basic lab work that will not require you to pay, it will not bankrupt you. And I know for a fact, where I live in Florida, we have community clinics, and a lot of underserved patients and a lot of immigrants are getting service in getting medical care in community clinics, as well as public hospitals, community hospitals.
Yeah, the long COVID clinic that I see here in Kansas City is part of the public system. And I really appreciate that.
I do want to speak to that too. And I trained at UCSF San Francisco General. So San Francisco General Hospital is the safety net county hospital for all of San Francisco County. For people who are concerned that like, oh, we're not going to get as good of care, the physicians who work at these hospitals do it for a reason. They do it because they love it, and they are the most mission driven and truly some of the smartest, most hardworking physicians I've ever met. And so I would not for a second think that like it's not going to be an equal quality of care. The problem is that they're just underfunded and they have longer wait times. Like there's no way around that fact, because people need them, because healthcare is far too expensive in this country. So people need those services. You can access them, but they do have longer wait times. So trying to establish care there, if that's the option that's available to you, absolutely do it. Those are my people. I would work in a county setting if I was able. Where I live now, we actually don't have a county hospital. So what do you do if you're in a setting where you don't have a county hospital? So I live in Sacramento County. In Sacramento County, there is no county hospital. So what the city had previously decided to do was distribute money to the hospitals evenly, to say, go take care of our patients for the county. And here we're going to provide you some funds to do that. And you're going to provide what we call uncompensated care, knowing that people are going to come in and they're not going to be able to pay and they're not going to have insurance. And the hospitals are funded to do that. And so they have, as a result, some form of charity program. So if you go in to a hospital, if you don't have a county hospital, if you do, that's probably your best bet, because that's the place that's funded for it. If you don't, just go into a hospital that you think will provide you the best care, is the most accessible to you, and ask them about those services, because generally places will fund uncompensated care, knowing that that's going to happen, whether they do it through one county hospital or through distributing funds throughout the county. The hospital, there is going to be a place where you can get care. And there is a law called EMTALA, which is the Emergency EMATLA, or Emergency Medicine and Active Labor Act. Which requires that you have a medical screening exam performed if you present to an emergency department. If you are in active labor, you have to be able to be admitted to the labor and delivery unit and be able to give birth there. And if you are having any life or limb threatening emergency or potential life or limb threatening emergency, you have to receive treatment. If they don't follow that, then that's a violation of EMTALA, and the hospital is fined for that. So those are just things to be aware of. Again, it sucks to have to be stuck being your own advocate. You shouldn't have to be. Chances are that it's going to be unlikely that you will have to be, because all these rules are generally followed because they come with severe penalties. But just being aware of them is helpful to know, so that you're able to be sure that you are protected and that you're able to access care safely and in the most cost-effective manner for you.
Yeah, and I think it's really, my dad is a hospital administrator, so he kind of dragged me into this when I was 15. It's also really important to know that it's not the hospital's not trying to work against you, and if you keep in contact with them,
Right.
a lot of people are more than willing to work with you to find a solution. But
Yeah,
the most
absolutely.
important thing is, if something is wrong and it's come on suddenly, please go in. Please just go
Uh,
ahead.
I would also add, since I don't know who in your group, who are the people in the group and how far they are living from their closest hospital, but I do work also in rural settings. I do some travel work, and so sometimes if you know that your hospital is some 50 miles away or 100 miles away and things like that, then with any new symptoms, you may want to start seeking care rather earlier than later, because later it may be already permanent damage done. So, and this is something that it's not rather about the choice of the hospital, but just seeking the care. If you're far from any facility, seek care early.
And maybe get a friend to go with you. If you think you're having a heart attack, please.
Well, they usually they
Yeah.
have like critical access
Yeah.
hospitals, or they have
Mm.
smaller like units, and just if whatever is available closer to you, go there, and they will take care of the transportation. And usually when you work in the bigger hospitals, you accept often patients from very small hospitals, and it's their already problem how they decide, depending on the patient condition, either it's ambulance or it's air lifting. But basically seek care if you know that the hospital is far and all is available to you is a 20-bed small unit, or not even just an standing ER of some sort. Then you just go there and let them figure out if you need to be transported.
Yeah, I've literally had people like, oh, I'll just go in, and it's like a 30-minute drive. What? Oh, let's call for
Yeah.
help. Call for help from someone.
Yeah.
I've been on both sides of that. I've worked critical access. I've worked in big academic centers and just large receiving hospitals. And when you're on the receiving end, like the goal is if you have the availability, right? The reason to transfer is you're at a place that doesn't have the level of care that you think a patient needs. So if they're having a heart attack, the treatment is to get them to a cath lab so they can stent open the blood vessel of the heart that's blocked, right? Where I worked in critical access, we didn't even have a cardiologist in the city or the town. We didn't have a cath lab. And so we often flew people to the nearest hospital that did have a cath lab. Now, unless there's like an active procedure going on, cath labs often open. So if you had somebody who's like actively having a heart attack, the closest hospital will be available to send. So the closest hospital with the cath lab will be the place where you send them. The other problem is if you are having a condition that's not as much of an emergency that they need to be transferred immediately, like to get to a cath lab, but they're worried that, you know, you do need what we call risk stratification, you need a stress test or that sort of thing. Then you have to find a place with available beds. And sometimes that meant transferring people like states away. Sometimes that meant like long ambulance rides. Sometimes that meant long flights. But if you're in the receiving center and you have a bed, the goal is to like try and get people there, right? Like you want to be able to provide that help that other physician, especially knowing what it's like to be in the emergency department on the other side, and you're trying to send somebody out and you want to get them to the place that they need to go because you know that you can't help them. So they'll do all of that work for you and they'll get you to the place that you need. It is also okay in that setting to advocate for yourself. I was in Oregon at the time, which has a law where you can go by private vehicle. So I'd have people like leave and drive themselves 5 hours because they didn't want to risk the cost of ambulance transport. That's fine. You can do that. That's just be aware, like that's a discussion you should have, and you should bring that up if you're in the setting where you might need to be transferred.
I grew up in rural healthcare. I never doubt what rural hospitals can do. This is what they do. They know they've only got 16 beds. Right. They specialize. Like you can have the tiniest little hospital. There's a helipad out there. They'll get you to Denver.
Yeah.
Yep.
Well, thank you so much. Are there any final thoughts that you'd like to throw out for us?
I did want to say one thing. First of all, Amanda, thanks for inviting me to come on. There have been a few papers recently about COVID, people who have simply had COVID, not just COVID long haulers, but just COVID in general. Again, this differs a little bit by vaccination status now, but early in COVID, when the studies were done, people had higher risks for heart attacks and strokes in the immediate following period, which they followed these people out for I think 4 months, the most recent study that I looked at, than the average population. So if you've had COVID previously, and especially recently, those are things to not ignore, right? Just because it's a higher rate doesn't mean you're going to have a heart attack, but it means be just a little bit more mindful of it. And so that's why I think it is an important discussion to be having in the setting of, having had COVID. I think that's an important discussion to have and something that's important to think about.
Thank you. Yeah.
I would also add something that I think if after COVID you have persistent symptoms, and we know the discussion about the long COVID, and so I would just say, go see the doctor to make sure what is behind those symptoms, because now we are seeing patients that are coming back struggling with shortness of breath after COVID that never went away, and until the moment that the person cannot breathe. And apparently it's progression of the lung condition to very severe stage with a lot of scarring. And I'm not saying necessarily that 2 years ago when you what to do, or a year ago when you what to do, and even now we may not be able to 100% help, but at least we could do an investigation, and at least we can fix if something is fixable early. Or let's say there is a problem with the heart function after COVID, and somebody starts looking for care when it's an emergency only. But usually I'm hearing from patients that, oh, since I had a COVID, I started getting this symptom or that symptom, and it progressively got worse. Don't wait until it progressively gets worse to the point that it becomes an emergency and ICU admission. Start seeking care earlier when you have this persistent symptom, so you can get additional testing done, because things like heart failure, decreased heart function, they can be figured out early. You don't have to wait until it is very significant, decompensated, as we call it in our settings, decompensated heart failure. And if you start having occasional chest pain with exercise, also seek care, see your physician, get a stress test, get ultrasound of the heart so that you can see, because it can be what we call coronary artery disease that doesn't have to become a disabling heart attack. So if you have those symptoms, go get checked. And again, I know we've discussed it becomes costly to patients, but there are ways to get checked with a lower cost.
And I think it's also very frustrating. I've got 15,000 people in this group. About a third of them were sick in that first wave. And with all the long COVID clinics, most of them require, because it was part of the CARES Act, most of them require you to have a positive test on your record. These are people who got sick before there were tests. So we've been fighting for that. But in the past 2.5 years of creating that path through the jungle with that machete, going through all this tests, going through all the testing and everything else, we do have a few more answers now. So I know it's hard. Just keep going, and if something is wrong, and you know what, just go in, just go in. If you need to tap out for a while, tap out, but get back in the fight. Well, thank you so much, Natalia and Taylor, for joining us. I'll get this posted in the group. Taylor, I was having tech problems early. It used to be really easy. You could just stream it right into the group, no problem. And now it's IDK. But thank you so much for coming. I am going to hit stop.